Great, thank you so much everybody. My name is Rafia. I am frailty lead pharmacist for Cwm Taf Morgannwg Health Board, and in part of my job I also deputy pharmacy for 2 community rehab hospitals. I'm also board member for Royal Pharmaceutical Society, which is the professional body for pharmacists in the UK. And the reason I wanted to do this session today is actually, as the name said, I in frailty, which means what are we doing? Who am I in the frailty provision within our roles and services? And I was hoping that I can give you something today that you can take back to at least start thinking about or incorporate or expand on when you go out. Because when I took this job, frailty was a mammoth task. I just didn't know where to start, and I feel a lot of people resonate with my story as well. And I thought, okay, if I share my journey, hopefully there's something I will be able to share that you can take back and expand on. The session is designed that everybody, whether they're experienced or new or thinking about or just coming across, will be able to take something with you back home. Normally I would have a screen to project my thinking on, but I don't have that today. So what I want to initially start with is why do we talk about frailty? We all know the data around aging population, comorbidities and all of that. But if I can just bring this screen for you, this graph, for you to ponder upon. Can you all see it? I'm so sorry, I wasn't prepared to present on the table. Right, so as you can see, this is essentially a representation of how people's ability or independence change as they become frail. Frailty historically have been used as a synonymous to aging and older people. Lots of people call them COTI, care of the elderly, but we know over the age of 65 only 10% increased risk of frailty, and as you go to 75 and plus, the increase is by 30% rather than a huge, like it's not definite. There are at least 15% people who are under the age of 65, but that's classed on the frailty register because of the other presentation of frailty. Anybody can tell me the number of risk factors you think are there for frailty? Higher. Higher. 24. Yes, is the highest that has been reported in the systematic reviews. And they don't all individually cause frailty, but the combination of them are going to make you likely to have frailty. So what happens here, you've got a non-frail person and you've got a frail person. This is their functional independency, which means they've got that buffer. Something happens to them which is called a stressor. This could be an infection, an illness, a disability, an incident, an accident, whatever happened, and they have that dip. When we are off sick for 2 days, we're unwell, we're not feeling very well, and then we go through that curve of healing, grief, whatever, recovery, whatever we call them, and then we go back to, hopefully, how we were before, with the same level of independence. In a frail patient, however, as you can see, the buffer that they have is very small, which means when a stressor hits, if this stressor is the same size, it's going to knock them really down to their functional disability, which means they are unwell, they can't do the things they can do previously, or they need carers, for example. What is really interesting is in this episode, yes, we know the recovery is longer, the curve is deeper, they may never go back to how they were before. And my interest is, what are we doing as healthcare professionals during that curve phase that's actually making them worse than they come in with? It's possible we didn't do anything. It's possible there's just nothing we can do to make them any better or take them back to how they were before because they were frail. They were, I don't know, 45 kilograms when they come to us, they're broken a hip. It's just not going to be possible to go back to that level. But is that true for every patient we see? Possibly not. So, another thing I want to talk about frailty is when you go back to your normal day-to-day life, is when we use this term, it can be interpreted very differently by people. So on this picture, can any of you take a guess? This is from Age UK, the word cloud. One is done by one from healthcare professionals, the other by patients. Which one do you think is by whom? Yeah, and the other one? Healthcare professional. Yeah. So end of life. Can you see how big that is? Is that how we see them? If that's how we see them, is that how we treat them? Yeah? Are we working on making them functionally independent when they leave our setting or not? Probably not, because it's what we think, isn't it? And then if you think about patient, and if you tell, I think your mum is frail, therefore we need to do this, this and this, and thinking, is that what's happening to my mum? Yeah? So that emotional aspect of behaviour that we all talked about this morning, that are going to come into play. So these are no answers. These are just the things for you to keep in your mind, keep thinking, reflecting when you go back home, so you can bring in your service. Now, I'm going to share some facts here. So why is everybody talking about frailty now? Yeah? So Rafia Wales document came out 5 years ago. And then last year we got Further Faster document came out. Earlier this year we got the Integrated Quality Statement come out for frailty. Frailty has been on the horizon everywhere. We're a bit late to the party in Wales, I feel personally, but we're there now anyway. So, the statistics tell us that 1 in 4 people will be over the age of 65 by 2038. 1 in 4, that's staggering. Yeah? By 2041, 75 and over age range is going to change from 9.9 to 18.3, just double. And that's 75 now. Keep thinking about what's happening to these people when they've lived another 10 years of their lives, with all the stresses we've just talked about. The other thing that is important, by same figures, same numbers, same years, 2/3 of those 1 in 4 are living with long-term conditions, probably multiple. This was really important for me. Our community and our society has changed so much that 40% of our 65 and over are now living alone. It's not hard to see it in our services, is it? She lives alone, she can't be discharged home. She lives alone, she needs carer. She probably was working before she came to our hospital, whether it was a shop or a tenant on the till or whatever, but she had a life. And we have the stress has taken the independence away. What are we doing to make it any better? The other thing, obviously, we all know the increase in dementia. Now, that is the number on dementia registered. That doesn't mean more people are having dementia. They're probably more registered, so we are more aware. But we all are so great about collecting data. But what do we do with that information? So if dementia register is telling us, we now know these many number of people are living with dementia, what are we doing to make sure that they are living with independence as long as possible? So what does that mean for us, healthcare providers? We know it's shocking, we know it's not looking great, and we need to do something to change it. If you look at this graph, which is very small, because again, apologies, I wasn't prepared to present on my laptop. This is the bars are to present the decades of your age from left to right. This side being the older, 90 plus I think they are. Yeah, 90 plus. The colors on the bars represent the number of medicines they're taking. The yellow is 8 or more. The grey is 5 or more. So this is where they start at 75. If you look at that, we know, this is the data now again, telling us that we know statistically these people are taking more medicines. Okay? The data also tells us people taking more than 10 medicines are 300 times more likely to be admitted to hospital with medicine-related side effects. 2/3 of those admissions are believed to be avoidable. The graph I've shared has come from overprescribing report that was issued in 2021. What does overprescribing mean? That means a medicine is being given to a patient to treat a problem or a symptom that can be helped without medicine. Yeah? The other type of overprescribing is they were started on a medicine, laxative. They were taking cocodamol at that time for back pain. Back pain is now gone. They've stopped the cocodamol, but nobody told them what to do with that laxative, so they're carrying on. The third problem could be they had hypertension. They were 54 years of age. They needed to control their blood pressure to make sure the risk of their healthcare-related problems. They're now 84. They're still taking those 4 medicines they were giving them, which is keeping their blood pressure at 120, 110, increasing the risk of falls. So these are the examples of overprescribing. And this is the picture I referred to earlier. That this is how I felt when I took this role on. Say, what do you want me to do about it? It's a whole mountain. I don't know where to start. Population is growing, I can't change that. People are taking more medicines, I can't change that. They're sick, they need medicines, I can't change that. So what do I do? And the other point is, it's not just what's on the top. Yeah? So we all heard about patients' beliefs, healthcare belief, all of that, which is underneath as well. But wherever you want to get to, we'll start with one step at a time. And I'm going to describe a few steps that we have taken within my role, which I feel have made a start, and I'm going to share what we want to do to expand on, and hopefully you can take something from it as well. The other thing I want to not spend too much time on, because we've all talked about that this morning, is the shared decision making and where does the patient fit in there. In this picture, this side is value-based healthcare and this side is medicine optimization. Value-based healthcare is very close to my heart because over the years, pharmacy as a profession has come a long way from changing the perception that this is about the cost of the medicine, and that cannot be the only reason to describe or define that something should be used or not used. It's the value to the patient and value to the healthcare system. They both need to be combined. So we've talked about what matters to the patient, we've talked about what matters to the healthcare professional. To give you a very topical example, heart failure, preserved ejection fraction, dapagliflozin, it should be prescribed. Patient's value might be they don't want to take it as medicine, they're 80 years old. But we do know that the data tells us that if they do take that, we can improve their quality of life, we can reduce mortality, and we can maintain their functional independence. That is value to a healthcare professional. But that gap we have in the middle, if we don't bridge that, they're going to go home and not take it. That's why it's important. So, where do we start? You will have answered some of the questions on the survey, which will tell me, which I'll work with AWTTC to see, are we doing something with all the information we think we provided to all the healthcare professionals out there? Are we actually generating any value from them? If not. So these are the things that you can start working on with regards to frailty. I don't know which services you work on, so we talked about stressor, we talked about what we do to the patient that takes their independence away or doesn't give them back to the level. These are the list of tools and medicines on there that increase the risk of falls and increase and contribute to adverse effects if they are frail patients. So what I have done in my role is list of these medicines are now part of our regular medication review if we are seeing that patient within my rehab sites. Okay. So we're not probably seeing every patient, but we are triaging them based on are they on this, if this is what they receive. So kind of a triage system. There are two other tools that you can use. One of them is high-risk medicines. So if your patients are taking them and you're doing care home reviews, for example, and that's got 600 beds, where do you start? You can't possibly review 600 patients. So you pick who are your high-risk patients based on this triaging, and you can do that. The other thing that I'm going to shortly start working on is sick day rules. So I did a piece of work a couple of years ago in my previous organisation. They were trying to get data. How often, as a practitioner, when we see a patient who we are starting medicines that have sick day rules associated to them, or reviewing them, tell them about sick day rules. We also did a survey on healthcare professionals, nursing homes, and domestic, what are they called? Residential homes. If those people actually know how to look after the patient if they're having a sick day. And the information we got was less than 60%. Half the time, we're not even telling the patient, if you have diarrhea and vomiting, what to do because you're taking this medicine. What's happening? They develop AKI, they go to hospital. They probably fall down, break their hip, and then they go to hospital. So these are the small projects that we have run, and you can expand on them as well. But what is really key, and if there's one thing you can change when you go into service, is people who are over the age of 65 and are taking anticholinergics. Anybody who have anticholinergic burden of 3 or more is 15% more increased risk of developing dementia. I'll show you some numbers. These are the number of papers in PubMed that have been issued up until 2022. There is now enough evidence to tell us if they are taking more medicines that have anticholinergic burden, and if they are taking medicines they have which are high doses of anticholinergic burden, they are more likely to develop dementia and cognitive impairment. So this is now not thinking anymore or anecdotal anymore. We've now got longitudinal studies that are proving us and giving us that data. There's another study that's come out, the one on the top, that tells us the sooner you take the anticholinergic burden away, the further you're pushing the risk of dementia. So you're increasing the gap. If they were to develop dementia, you're progressing that gap as well. So now it's not only about stopping the anticholinergic, but also stopping them in time. If they're 40, don't think they're not 65 yet. Do they absolutely have to have that burden? Is the question we need to start asking ourselves. Because we are currently in a situation we are dealing with frailty, but we are not preparing with how to avoid living with frailty in future as well. So if I go back, this is a tool.
This is a 5-minute warning.
Which is a validated tool. And it is really good because you type the medicine in, it tells you straight away what is the risk of that medicine. It also tells you if within the same group of medicine for the same condition there is a medicine available which doesn't have the same risk. Every organisation is free to use whichever tools they want to use. There's no validated or whatever tools available, which is why you answered that question as a survey for me as well, because I want to know what's happening in Wales. But if you, this is one way for you to, every patient you see within your service, whether you are doing a care home review, you are doing medication reviews in your practice, whether you are seeing them in your community pharmacy, for example, if you do know what your ACV score is, then you can start. Well, the target is nobody should do more than 3. And anybody who is on amitriptyline has got a risk of 3. So the other thing of why is also important, that it's not just dementia, it's not just about the risk of cognitive impairment, it's also anticholinergic burden can lead to cascade prescribing. If you think about how they actually work, they are causing blurred vision, they are causing dry mouth. People don't even probably understand they have got dry mouth, they probably just think they've got stutter, they can't talk very well, their ability to speak is going away, but actually it's just dry mouth. The other thing that's happening to them is their gut is flowing slower. I'm sure you know all these clinical things, and as a result they're having dyspepsia, indigestion, heartburn, and they're ending up on long-term PPIs as well. So you can see that with one medicine which might be helping them, I'm not questioning that, but can we do anything to actually improve that bit so we don't have to end up on 3 more medicines to stop, get the laxatives on because they got it, because they're having that problem, they dry mouth, eye problems, no, as you know, as we age with frailty, you've got dry eyes, probably anything.
What's the risk? I know it's not an anticholinergic, but what's the risk of gabapentin or gabapentin?
They increase the risk of confusion in elderly, and with increased risk of confusion, there's an increased risk of fall as well. I did have a slide which I've taken out, which actually talks about which medicine causes what, that increased risk of fall, but I thought it's just too broad of a topic. But gabapentinoids, both gabapentin and pregabalin, do directly contribute to risk of falls because of confusion, and it's actually to do with how the coordination between your receptors and your muscles will work, and there's a delay. So your brain might thinking, I'm ready to go, but your muscles aren't ready yet because of that delay, and that leads to fall as well.
In your opinion, as a physio, I prescribe for pain, and in the elderly it's a minefield.
Yeah.
Because,
it's very interesting.
Where do we begin? Because none of them can take NSAIDs pretty much.
Interestingly, the evidence in terms of how much it's going to, I'm presuming you're prescribing them for neuropathic pain.
Yeah.
The evidence is really underwhelming.
But I suppose, but we ends up.
It's where do you go, isn't it?
And that if they're in pain, they're not mobile.
Yeah.
So then
there's a double risk.
There's a double risk of falls, and then because they're losing their strength.
I think there's
and
no harm in
independence, so they're
trying, as long as you set out from the start that what are your treatment goals are, how long you're going to give those goals to be achieved, and then you stop them if you're not getting them.
Okay, that is now
Actually,
the end of the first
duloxetine's
session.
got slightly superior evidence
I
for
think it's
neuropathic
celebrated
pain,
in
but
the
it's only
first
licensed
session
for
in
diabetes.
UK.
So
But,
that's where I think
if you could just make your way to
that
your
discussion
next
comes in,
group.
that there's no, these are grey areas, we don't have evidence in frailty, and
That will
I say
be
this
session
often,
2.
as healthcare professionals, we probably are the first generation of healthcare professionals dealing with this level of frailty and high level of prescribing, and if we don't generate the evidence, our followers are not going to have anything to work with. So I kind of take that responsibility on myself as well to say,
Did
you
it,
need to
did
do
it,
enough
did
to
it.
know that. So yeah, I can't answer that question.
That's okay.
But it does increase your risk of fall. So I'd say try it, and try it in a way that you have clear goals, what I'm trying to achieve. Your patient should be on board as well to say, if that's not helping, I'm stopping it because it's going to do this instead for
I
you.
think it was more your opinion of whether you would go for amitriptyline or a full pregabalin reduction.
So amitriptyline, if you think about it, has got other bigger picture things going on as well with regards to anticholinergic burden, as well as it has the depression and anxiety side of benefits as well. So it depends what your patient actually needs. How many problems you might be trying to cater for by giving one medicine. Because if they're let's say they're 80 and you're giving them amitriptyline, how, again, coming down to how long do you see that person to then have that risk of dementia is my question.
Yeah.
And if you don't see that person being around for 5 years or 4 years,
Is that risk benefit so together? Yeah.